For Lesson 4, the learning objective is understanding the criteria for the remaining WHO-UMC system categories and how the Naranjo algorithm compares with this system. Looking at the remaining categories, we start with possible. A possible adverse reaction report may be explained by other drugs or diseases. Like a probable reaction, we have an event or a laboratory test abnormality with reasonable time relationship to drug intake. Beyond that, there are several reasons for classifying a reaction as possible. The suspected reaction could also be explained by other drugs the patient was taking. Disease might also be an explanation. For example, if we have a report of pancreatitis with a drug used to treat diabetes, there is a problem because diabetes itself can lead to pancreatitis. Furthermore, a possible ADR report does not require D-challenge. Another reason for a possible classification is lack of information about outcome when the suspect drug was stopped, that is on D-challenge. In some cases, that information will never be available. Stopping the suspect drug does not always lead to recovery, even if it did cause a clinical event. Maybe it was so serious the patient died or was permanently harmed. Maybe the event was pregnancy due to an interaction with an oral contraceptive. The pregnancy will of course continue even if the drug is stopped. An unlikely adverse reaction report may have an improbable time to onset or a more likely alternative explanation. An event or laboratory test abnormality with a time to drug intake that makes a relationship improbable before, for example, the drug was started, or too long after it was discontinued, or it was not in keeping with the known time to onset for a recognized adverse reaction. For example, it would take longer than 1 day for hepatic failure to occur after exposure to a drug. And then disease or other drugs provide plausible explanations that are more likely than the suspect drug. Unclassified adverse reaction reports usually contain very little information. Sadly, we receive a number of reports that really have very little information in them. For example, we might have reports that say that the patient took the drug on an unknown date. They had the event on an unknown date. We don't even know if the event occurred before or after starting the drug. We suspect it occurred afterwards because it was reported, but we can't be sure. So we say these are unclassified. Some people also use this as a conditional category for unexpected reactions that don't fit with our knowledge about the drug, and the information in the reports is limited. They may add evidence later if similar reports are submitted. Finally, we have unclassifiable reports. These reports have insufficient information and no more is expected. An algorithm such as Naranjo's is an alternative standardized way to assess causality. This is rather a different approach since scores are given for different elements rather than the more reflective approach of the WHO-UMC classification. The Naranjo algorithm is one that is widely used. It is made up of questions about the data you have, and the answers result in positive, negative, or no scores. The scores are then used to assign the reports to 4 categories similar to those in the WHO system, but not the unclassified and unclassifiable categories. They don't appear in the Naranjo algorithm. The algorithm was developed for clinical trials, and so has some questions that are not usually relevant to adverse reaction reports, such as blood levels of the drug and response to placebo. However, many of the elements in the WHO-UMC criteria are included, and the results of assessments are usually similar. If the final score doesn't fit with your overall impression of the report, you should use your judgment as to how it should be classified.